record. Okay. All right. So just a couple housekeeping and Zoom basics. Because this is set up as a webinar, everyone's cameras are off and you're muted. But if you would like to speak, I have the power to unlock your microphone. So feel free to either type a question in the chat box. You could raise your hand like Veronica did. So we can open your mic, or you can just type into the chat box. Feel free to ask any questions as they come up, and we'd be happy to answer anything. And we, again, want this to be an interactive presentation. So we welcome your questions and we welcome your participation. If you will be typing in the chat box, you might want to change your chat box setting to all panelists and attendees. That way everyone can see the question that you type or the comment that you make. Otherwise, just Dawn and I will see those questions and comments. So it makes it a little bit better if everyone can see that. So in your chat box, just change panelists to all panelists and attendees. And then we'll get you started. And as I mentioned, this session will be recorded, so anything you say will be used against you. Our presenters today, this is Dawn Reinhardt Wood. Dawn and I am Jen Sperduto, and we are both from the Rutgers University Department of Psychiatric Rehabilitation and Counseling Professions. And Dawn and I work on a team of embedded consultants at the New Jersey State Psychiatric Hospitals. So we have a lot of experience in preparing people for discharge to the community. Dawn has worked in supported housing for many, many years before coming to the state hospital system. So we will be your presenters today. That is me. And without further ado, I'm going to turn it over to Dawn, and she's going to tell you a little bit more about what we're doing today.
Thanks, Jen. I appreciate it. So hi, everybody. And like Jen said earlier, please, if you have any questions or comments, or especially real professional, on the job kind of experience with some of the things that we're talking about, even if you have bad experiences or have experienced significant barriers in delivering the types of services that we're going to be talking about, we want to hear that, because especially, and this is why we want you to change your chat box to all panelists and attendees. We want this to be a learning experience for everyone, and especially drawing on some of the experiences that you have already had. I think that, on top of some of the basics that we're going to talk about, those experiences that you've had, that we've had, are extremely important, and it could lead to a very fruitful discussion. The other thing that I wanted to mention is I do believe we have Kimberly here from Washington State, and she will also be able to answer some more specific questions about FCS services should they arise. So we have 2 hours today. I'm not sure that we're going to need all the 2 hours for the presentation, but that will allow us significant time for any kinds of questions and answers that you may have about this set of services in the IMD settings, okay? So you will have that opportunity to ask those questions, not only us, but to representatives from the state of Washington who are here. So today, what we're going to do is we have basically 4 objectives. We're going to look at psychiatric rehabilitation, define it and distinguish it from psychology and psychiatry. Psychiatric rehabilitation is something that's a little much less known than psychology and psychiatry. Excuse me. So we're going to spend a little bit of time distinguishing that. We're going to review supportive housing, FCS services, the philosophy and services that are provided within supportive housing. We're going to identify supportive housing services that can be provided or adapted for the inpatient IMD environments, and describe ways in which staff can provide supportive housing services, can partner with community providers to enhance discharge success and reduce reinstitutionalization. And to let you know, although we're on different coasts and we call things slightly different, right? Our supportive housing is called CSS. Yours is called FCS, or it's within the FCS set of services. Here in New Jersey, it's within the CSS set of services. Both coasts are experiencing very similar movements in terms of encouraging people to move towards supportive housing in order to reduce, the rehospitalization, reincarceration, relapse for all. So this is something that I think many mental health systems across the country are now working on, and in some cases struggling to implement. Can you advance, Jen? Thank you. So what is psychiatric rehabilitation? In our chat, I'm just wondering if folks have any idea of psychiatric rehabilitation. When we talk about it at times, many folks aren't quite so sure. So if there's any folks out there who may be a certified psychiatric rehabilitation professional, which is a title is a CPRP, or in other ways, look at Jen. What is PSYR? In any other ways, if you had experience with psychiatric rehabilitation, we'd like to hear from you. So psychiatric rehabilitation are in fact services that are aimed at specifically improving a couple of things within the individual. So it is clarifying an individual's role, right? So what does this person aspire to be? What is this individual's, we call it valued social role or valued life role? So finding out from an individual, what are those roles that they occupy, that they value, that are important to them? Now, if you think about yourself as an individual and think about how many roles you occupy, and I'm not going to ask you to necessarily put that in the chat, but just think about that. What are the important roles in your life? For me, number one comes, I'm a mom, right? I want to be a good mom to my son. Number two, probably lecturer or faculty at Rutgers, right? So that's something, my career is very important to me. Friend or daughter, right? All of these things that an individual may hold as valuable, as meaningful to them. And meaningful is the key word here. And we're going to talk about that as we move on, and how meaningful life roles can connect to goals and outcomes that we see also as important for the people that we work with, whether it be continued psychiatric stability, whether it be continued community tenure. These are things that we can connect that support the individual's valued life role. It's very difficult to be mom, to be a great coworker, to be someone who helps improve other people's lives, whether by teaching or by social working or by counseling, when we are not feeling well enough, when we are psychiatrically unstable, when we are, in a spot where symptoms are very, profuse. So that meaningful role is extremely important when we talk about goals in psychiatric rehabilitation. The other area that psychiatric rehabilitation focuses on is the way the individual is able to function in an environment. So we say an environment because we know that we occupy many environments, right? Might be our home, our apartment, our school, work, our role in the community, as a volunteer, as simply as a citizen of our community, of the United States, and what that is to be a full-fledged integrated citizen in the community. So the second emphasis is to focus on functioning, and specifically the skills that individuals need in order to make it so that they are more likely to thrive, not just survive, but to thrive and recover in their environment of choice. And again, when we say environment of choice, we mean those environments that go along with their valued life role. Okay. Next slide, please. So many psychiatric rehabilitation services focus on building, enhancing, or refining the skills necessary for individuals to improve their functioning in a variety of settings. So we have a few pictures here. You know, an individual may begin psychiatric rehabilitative services while they're in the hospital. That may be their first introduction to these services, whether it be through groups, through individual interactions with mental health clinicians. It may be through interactions through peer providers. I'm not sure, and I'm curious if folks could type in the chat box. I'm going to assume that there are peer services throughout the Washington continuum of care for folks. I'm not sure what that looks like in your IMD settings or in, you know, hospital settings, but very often individuals may be introduced to psychiatric rehabilitation or an aspect of psychiatric rehabilitation through peer support services. And peer support is one of the recognized interventions in psychiatric rehabilitation, and it is an evidence-based practice. So there is evidence that when we receive support and intervention from individuals who have been there, who know what we are experiencing, what we are going through as a recipient of mental health services, whether in an inpatient setting or in an outpatient setting, there are improved results for individuals in the short term and in the long term. Peer supports have their roots in the addictions field. All you have to do is think about 12-step groups like NA, AA, OA, and that is a prime example of peer support, okay? And it has made its way into psychiatric rehabilitation because there is evidence that this works. And one of the things that we should probably say about psych rehab is that the interventions that are used are all evidence-based. So psych rehab pulls together a lot of different evidence-based practices that you may see pop up in psychology, psychiatry, in other disciplines, but we do pull together those evidence-based practices for use in multiple settings.
Hey, Dawn,
Yes,
just want to let you know, Samantha responded that they use peer bridgers for individuals in their psychiatric facilities to help transition into the community.
That is awesome. We actually attempted that in New Jersey a few years ago, Jen, remember?
Yes, we did.
Forensic peer bridgers is what we attempted. I think our system may be a little bit more, what's the word I'm looking for?
Behind?
Behind.
Lagging?
You know, guys, for a very long time, or actually I could say, you know, when we started working with Washington, we're thinking, you know, we're New Jersey. We're all, you know, we're fast paced. We're ahead of the game. We're, you know, but what we find is, you know, our system is very, very fragmented. And I'm sure, you know, the Washington system as well has those silos, has some fragmentations. Big systems of care are going to have that. No matter how many great people you have trying to move everybody in the direction of recovery, it's hard in a big system of care. We had attempted forensic peer bridging for individuals who were in our forensic hospitals. So those were individuals who were involved in some way with the justice system, and we just couldn't get it to work out here. Probably if we had started with maybe a slightly different population, maybe non-forensic, I don't know that it would be easier, but it was very difficult for a number of reasons. Not to say we didn't see 100% value in it. So thank you for that comment. I'm glad that that's happening out there.
Yeah, and Veronica shared that she's a peer in the PSH in Hampton Newport News Community Service Board.
Oh, wonderful, wonderful. So Amanda, that was Amanda? Veronica, I'm sorry. So Veronica, at the organization that I worked for before I came to Rutgers, I was there for 17 years. And I always say I'm very proud, although the credit isn't for me, the credit is to the grant that we were able to obtain. But I was very happy that our program was the first program in maybe like 2000 to hire someone to fulfill a peer role in our supportive housing program. And let me tell you, Veronica, it ended up that people would go to their peer support specialist very often before they came to their case manager or me as the director for assistance because they felt like that individual got them, right? They may not have experienced the very same challenges in their life or barriers in their life, but they did know what it was like to be a recipient of services and all the good and the bad that comes with that. And because we try to have all these boundaries and we don't share a lot of our backstory with our clientele, that's a way that like we have just a difficulty connecting sometimes. Yeah, Veronica, it's because when you know that a person gets your experience, at least on some level, it's easier to talk to that person. And I think that that's true for all of us, right? So let me move on from there because I could talk about peer support all day. But in work, right? We could psychiatric rehabilitation services may pop up as an opportunity to provide some to someone in the work setting, and we'll touch on some of those aspects of psych rehab that could be applied in the work setting momentarily. But and also school. So psychiatric rehabilitation also has an aspect of it called supported employment. So we'll talk about that briefly as well. Or I'm sorry, supported education, work, supported employment, school, supported ed, which I do think that your state is providing you with webinars also on supported employment. I'm not so sure about supported education, but I do know that you've been receiving some lots of webinars in supported employment, actually from Rutgers, I believe. And then family, maybe one of the most important environments or aspects of an individual is family. And I'm not just talking about family of origin, because we all know that as we move on through life, some of our family members may not be so helpful in our lives. I'll put it like that. I've definitely had this experience at different times in our life, right? Family may flow in, flow out. Sometimes they have to flow out altogether, or we make that choice that they need to go altogether. And obviously that's not ideal. That's not what we want. But sometimes people have to choose to rebuild their family and to surround themselves with supports, real supportive types of people that are going to be there and help them through their path to recovery. So psychiatric rehabilitation can also help with improving the individual's conflict management skills, communication skills, and self-confidence in other areas to help them really strengthen their role in their family of choice, not just family of origin. Next slide, please. So the three main, I'll call them arms of psychiatric rehabilitation services that we tend to see in the community, maybe not as much in, inpatient type settings, but what we see in the community and what we try to start to plant the seeds for while individuals are maybe in crisis or experiencing an exacerbation of their symptoms are supported employment, supported housing, and supported education. I'm curious if anybody has either worked in any of these program types or has experience with their clientele receiving them, especially supported employment or supported education, which may be a little bit lesser known. Unfortunately, I think that around the country, this is for sure a fact. I don't think that there's enough money and enough resources put into especially supported employment and supported education. But we do know from evidence, from scientific research, that they are both evidence-based practices, that they do make positive changes in individuals' recovery trajectory, and that they do support people in fulfilling their valued life roles. So supported employment actually pairs those skills teaching, skills teaching and career exploration and specific training to what an individual might like to occupy in terms of a role in the work environment. In addition to focusing on those career skills that an individual needs to build, supported employment very often pairs on the job coaches, mentors for individuals as they transition into the work world. Also, we don't necessarily expect an individual to just stop at that first job that they're able to acquire, or that first job that they're able to acquire out of that supported housing program. We want individuals to aspire to their ultimate career goal. It can be difficult at times when individuals say to us, you know, I want to be a doctor, and they haven't graduated high school yet, right? We say, wow, that's, you know, you're 45 and you want to be a doctor. Hey, I've had that dream in my head for a very long time. And I am 45 now, and I know I will at least not be a medical doctor, but, you know, helping the person to figure out what it is exactly about that role of doctor that they would like to occupy, right? And helping them work towards a job that helps them kind of get that benefit out of it. Might not be doctor, but at some point, maybe it's pharmacy technician, right? So it's not about people shooting lower. It's about getting to that job that possesses those qualities that they value, whether it's respect or helping others or being somehow involved in a medical field, because to that individual, that is the utmost in helping other people and feeling like they're giving back to their fellow man or to the community. I'm going to not focus on supported housing just yet. I'm going to skip over to supported education, then I'll come back to supported housing. So supported education is very similar in terms of finding out where those skills deficits and strengths are in an individual who is choosing to occupy the environment of education, choosing to take on the role of student, and understanding where they need to strengthen their skill sets. Very often, supported education, you know, starts with working with an individual who may have tried higher education before and not done very well, and maybe went back 3 times and you know, kept taking time off because they were struggling either with mental health symptoms, or perhaps it has nothing to do with the mental health systems. They haven't acquired the skills to be a successful student. I think sometimes we assume that everybody has the skill set that they need to transition into college, to transition into a trade school or a technical school. And that's not always a safe assumption. Does anybody know why, specifically when we're talking about people who might be living with a psychiatric condition, why they may not have that skill set automatically that maybe many of us already had and didn't have to work towards acquiring once we got into a university setting? Does anybody want to take a guess as to why individuals may not have developed those skills, like note taking, studying, asking questions of the professor, feeling safe enough to do that? I'm going to look at the chat and see if anybody. Why might people have not acquired those skills? Okay, struggles in mental health. Sure. And, you know, when we struggle with mental health, I don't know about you, but when I go through a very stressful time, it's really hard to focus on other things. I went through a situation recently where it's very, very, very hard to focus on work, school, everything else, when your thoughts are otherwise occupied, or when you're experiencing maybe some cognitive deficits because of depression or some of the other anxiety and stress. So I'm going to look at these answers here. So we see fear, absolutely. You know, someone with an anxiety disorder might be really, really fearful of, and I'm going to use a term that I use in my own head, looking back at taking statistics in our university setting, my anxiety went through the roof because I have a lot of insecurities around my mathematics skills. So I was very often afraid, petrified to ask a question for fear of being wrong and being embarrassed. So Samantha says those they lived with growing up also didn't have the skills to teach them. Excellent. Sometimes we see that psychiatric conditions and a lot of other social conditions like poverty can be multi-generational, right? So if my parents didn't have that skill set to teach me, or perhaps they were otherwise distracted and they chose not to teach me, I don't have the skills. These aren't necessarily things that come naturally. Alicia also said lack of life skills, mental health, and substance abuse were also noted. Sure, these are all reasons. And Jen, did you want to say
Yeah, I
something?
was just going to jump in for a second when you were done. I'm sorry, I thought you were finished.
Almost there. I just wanted to say one more thing, that also think about when mental illness can strike. Now, obviously, mental illness is equal opportunity in terms of gender, age, race, right? It can strike at any time. Somebody could enter a depressive episode. But what we know is a few of the major mental illnesses that can have the potential to be most debilitating, such as schizophrenia and bipolar disorder, tend to strike in the late teens to mid to late 20s. This is a time in our life when we are acquiring a lot of these skills. In high school, we're starting to learn, more technical study skills and note taking and ways to prepare, ways to write, outlining. These are things that individuals with mental health conditions may miss out on because their development was disrupted, right? Their development for moving them towards higher education may have been disrupted by the mental illness. Jen?
I was going to make that exact point, Dawn.
Okay, I saved your breath for you.
I was trying to give you a break.
Hi, Kimberly. Welcome. So that's supported education. So in supported education, the program will stay with the individual as long as needed throughout their educational career and offer very targeted supports. So it may be study groups, it may be teaching how to study, how to sometimes write, how to cope with the symptoms of a mental illness while you are also trying to occupy that role of student. So it's really offering some real practical interventions. And supported housing. I'm thinking that probably you are all most familiar with supported housing among this group, and that's why I saved it for last and probably won't talk about it as much. But supported housing is really the pairing of supports, so real-time supports in the environment that the individual chooses, and affordable, safe, decent housing where the individual can afford it, because that's really important, right? I know that in Washington State, as in here in New Jersey, I think New Jersey is either the first or the second in terms of most expensive states to live in, but everywhere, unless maybe you're going to the deep South or a very, very rural area, housing is expensive. It is really expensive. And if you are on a fixed income, especially SSI or general assistance, which is welfare, or SSD, it's a lot harder to meet the financial burden that comes along with housing. So supported housing usually pairs vouchers, rental subsidies, so that an individual can afford the housing that they're going to live in, along with these real-time supports from a team of individuals. So supported housing teams, and we may have some in this room today, or in this virtual room today, and feel free to chat it up in the chat box, but it usually looks like, a team of professionals, which often includes case managers, peer counselors or peer support workers. It could involve vocational support workers, maybe an addictions support or addictions counselors. So to deliver the needs that the individual has into their environment of choice. And very often supported housing staff are going into the individual's actual residence or going into the community where the individual is. I conducted a lot of sessions and a lot of interactions with the individuals that I worked with outside of places that they worked at. I would meet up with them in the parking lot, and we would sit and we would talk about their needs and what's going on in their life. It may happen in libraries, right? It may happen in the person's home, where we might be teaching them real living skills, helping individuals budget, helping individuals understand, how to manage a household. So really, like, the point that I want to drive home is supported housing can happen everywhere. So I see Veronica says housing stabilization specialist. Yeah, so having housing specialists who really focus on the aspects of making sure the lease payment is paid, making sure an individual understands what a lease means, making sure that the individual knows what their responsibilities are as a tenant and understand where they then cross over into the responsibilities of the landlord, right? There's a lot that has to do with living in housing. And again, we can't assume, and I think that that's the drive home point for all three of these major arms, is we can't assume that people have these employment, housing, or education skills when we are working with them, because when we do that, we do a disservice. So for each of these three interventions, assessing and doing checklists and understanding individuals' preferences for employment or education or housing is so important in being able to help the individual that is being served. Next slide, please. So supportive housing services specifically are ongoing supports that help eligible Medicaid clients find and keep stable, independent housing. And this is directly from the AmeriGroup definition for supportive housing services, which is, I believe, where the claims go through for supportive housing services, or FCS services, in Washington state. So this is their expectation for what supportive housing services will look like when being rendered in the community. And this is identical to New Jersey, I have to say, because this is the world that I came from, and this looks identical. So things like housing assessments, as I said earlier, finding out not only what skills the individual has or needs to build on or actually, produce or develop. Not only that, but also finding out what an individual's preferences are for housing. So does the individual have a problem with noise? Would they rather be in a second floor apartment because hearing people walk around is too disruptive to them or too anxiety producing? Maybe an individual would rather have a roommate because they know that in the past that when they became lonely or they have a propensity to become lonely, and maybe that leads them down a path towards depression or towards relapsing in their substances. So really finding out who the person wants to live with. Do they want to live in their own place, or do they want to be with other people? Do they want to return home to their family of origin, right? Or is that even not a possibility? Do they need to be near a bus route? Do they need to be near public transportation? Or do they have their own means of transportation? So all of these things are really important, and it's why it could be so challenging. And I'm just speaking here for New Jersey. Very often we're in the position of there's an available apartment with a rental subsidy, you need to take it, right? So, and then we wonder why people may stumble and have a difficult time because they weren't empowered as much to make this choice. So we want to start that very early. Identifying housing resources, so really educating people on what resources are out there to help them with housing. So are these, financial resources? Can individuals get assistance with things like utilities, low-income housing or low-income heating and energy relief? Do individuals need assistance with food insecurity, right? Do they need to apply for SNAP or food assistance? Do they know where local food pantries are? Even understanding the terms of a lease and connecting people to housing attorneys when that is needed, right? Because sometimes individuals get into situations where maybe they don't have such a great landlord. And so being able to enter in and help an individual know where the resources are that they can go to obtain assistance for hopefully remaining in their housing or finding a more suitable option. Support obtaining a lease. So in supportive housing services, typically or very often, the housing worker, it might be the housing support specialist or whatever you might call it, they may be an individual who accompanies your service recipient to signing the lease, to understanding the lease, to understanding what it means in the lease that refers to their obligations and the landlord's obligations. Crisis management. So supportive housing staff may also teach individuals crisis management skills, but also may intervene when there is a crisis, right? So we don't want our landlords who are working with our clients or our service recipients either to feel like, and I'm sorry, I skipped over landlord relations, but maybe I'll weave this in there. We don't want our landlords to think that they're out there alone, right? We don't want the landlords who maybe have never rented to someone who is using a rental subsidy or has identified that they have some kind of a disability or a condition that maybe the landlord hasn't seen before and maybe has some trepidation or fear or worries, because landlords deal with a lot. And I think sometimes we don't give them the credit for what they deal with all of their lessees, I guess you would call it, their tenants. We want to also educate the landlords while also respecting the privacy rights of our service recipients. But we want to be there also to be a support to the landlord, because what do we want from that landlord? I'm going to tell you what I wanted as a program director. I wanted more rental units, especially here in New Jersey. And I'm sure like in the bigger cities in Washington, like in Seattle, housing is very limited, and affordable housing even more limited. So we want to culture and cultivate these relationships with landlords and also provide them with the supports that they need, which may be mediation or negotiation at sometimes when the landlord and the tenant finds themselves in a struggle. Yeah, Kimberly said more housing everywhere. We really do need more housing everywhere. As part of my dissertation, information that I came upon around housing, because the focus of my dissertation is in supportive housing, but a certain aspect of it. One of the things that I came across was a study by the Corporation for Supportive Housing, which some of you may be familiar with. They're like the national kind of advocacy group for supported housing. And they do a lot of funding for supported housing development. But one of the things that they said is that there are still thousands and thousands and thousands of individuals, specifically with serious mental illness, who are waiting for supportive housing, or for whom, individuals who have been in long-term institutional care or group home care, and I'll throw that in with institutions, or group home care, who really could survive, not just survive, thrive and recover in their own apartment or in a more independent setting, but can't because the resources just are not there. And that's really sad, right? Because we want people in their least restrictive environment. And then independent living skills development. So this is where the skills teaching really comes in. So we're not just talking about, when we say independent living skills, these aren't necessarily the same as ADLs or activities of daily living. These are more, I would say, high level, but next level stuff. So things like budgeting, how to pay bills, how to get along with neighbors when you have a problematic neighbor, right? And so on, grocery shopping and applying for a job, asking someone on a date. This is my area of focus, the romantic aspects of individuals' lives, those social skills that people need, that all of us need, that some of us weren't taught or acquired because of an episode of mental illness that maybe got in the way of acquiring those skills. So, part of this is also assessing where the individual's skill level is and then matching them with the supports that they need to develop those skills. Next slide. Okay. So who is eligible for supportive housing services? Individuals experiencing chronic homelessness as defined by the U.S. Department of Housing and Urban Development. Unfortunately, I have this definition embedded in my brain because I applied for a lot of grants from HUD, and luckily we got a lot of grants from HUD, but it was 4 episodes of homelessness, 4 distinct episodes of homelessness in a 3-year period, or I believe 1 consistent year of homelessness without interruption, and women or individuals fleeing domestic violence who also have a serious mental illness. And Kimberly, if I'm missing anything, you can pipe up. But so these are the folks that we're talking about when we talk about chronic homelessness, right? So not just the individual who had 1 episode of homelessness, but those folks who this is becoming like a repeat instance in their lives. Those dependent on costly institutional care. So individuals who have been residing in the inpatient setting, group home settings, for a very long time. These services are exorbitant, as you can imagine. And supportive housing really is one of the most affordable services that has long-term positive outcomes out there. So those individuals who are stuck, really stuck in those institutions also. Individuals dependent on more restrictive adult residential care or treatment settings. So again, those individuals who may be in like a group home setting. Group homes are much more expensive than supportive housing, or crisis house type settings. These types of settings are very expensive and much more restrictive and may not allow the person to develop those skills that they need to flourish in the community. One of the things that supportive housing really professes is that you should be acquiring the skills or being taught the skills in the environment where you're going to use them. So Jen has a really great example. I think it's Jen has had a really great example before about, learning how to cook on maybe a gas stove. And then an individual gets into their apartment and they have an electric stove.
And they start a fire.
And I'm going to tell you.
Story.
Yeah. And I'm going to tell you that actually for me, something similar just happened. I moved from a place where I had a gas stove. Now I have an electric stove. And I was like, I don't know how to do this, and I'm 45 years old. And guess what? I have used an electric stove before, but it was in high school when I was in home economics, right? Probably 30 years ago. So, this isn't just for individuals who, we're not just speaking towards individuals who have a psychiatric condition who may not have these skills. We all, I think, know what it's like to get into a situation where, or learning how to drive a car. You learn how to drive in a manual car, and all of a sudden you need to use a stick shift. Wow, that's difficult, right? So teaching people the skills that they need to acquire in the setting that they're going to live in is the ultimate goal. In-home care recipients with complex needs. So when you think about, individuals who have psychiatric conditions, there are some individuals who also have a lot of medical stuff going on for them, right? So, some individuals may be homebound. So also meeting their medical needs and those other needs in the community rather than in a nursing facility, a skilled nursing facility, which is where a lot of folks, unfortunately, with severe mental illness and complex health conditions, unfortunately, may end up in these more restrictive, more costly settings, and they're not allowed to flourish. And we see this here in New Jersey. There's a lot of people in our state psychiatric hospitals who are older, who have a lot of complex medical needs, and they're just stuck because there's not a fit for them in the community yet. And those at highest risk for expensive care and negative outcomes. Next slide, please. So supportive housing settings, where do we deliver these services? So traditionally, we looked at delivering services primarily in the individual's home. And one of the reasons for that is because of some of that skills teaching piece, right? Not only do we want the individual to be comfortable, we want to meet them in their environment and make engaging in services as least cumbersome as possible, which is why we try to deliver it to them. Providing those skills teaching in the home, again, in an environment in which the individual is going to use this skill. But we may also meet them at our office space, right? They may come to us for services if they feel more comfortable doing so. I've had tenants who didn't want me to come into their homes. They may not have wanted people to see what they thought was a staff person coming to their apartment, although I would always take off my badge and try to look like a friend, right? They just may have been a little insecure about that. They may have some, fear about that. They're depending on what the individual's condition is. There may be, a little bit of fear around having people welcomed into their home. They may just be more comfortable because it's what they've always been used to, is meeting in an office, wherever the person feels most comfortable. It may happen in libraries, in parks, in coffee shops. And I even listed here bus or public transportation. So think about the skills teaching. It's really hard to teach somebody how to use public transportation if we're sitting in their apartment. Now, we may sit in their apartment to review the bus schedule or the subway schedule or the, whatever, that schedule. But at some point in time, they need to transfer those skills to the actual setting that they're going to use them in. So let me tell you how I learned how to ride a bus in New Jersey. I learned it by partnering with one of my clients to teach them how to do it. I was 22 years old when I learned how to take a bus in New Jersey because I never had to do that before, right? We learned together how to ride a bus. And I think that put the person at ease when I said, you know what, I've never done this before either. We're going to figure it out together. And we did. Now, would I want to take a bus again? I probably have forgotten what I'm supposed to do. But, that's just an example of there's some of us we don't have those skill sets, right? Because we didn't need to learn it or we weren't exposed to it. And I put here even coffee shop, right? So not only coffee shop, like we're going to get together over a cup of coffee, we're going to talk about how things are going for you, where your goals are at, what you have done to meet, some of the short-term objectives of those goals, but also maybe the person needs to get comfortable in being in a social environment. Maybe the individual who is experiencing hallucinations needs to figure out, how to be in an environment with other people in a social setting, in a space that might be busy, while also, handling their psychiatric symptoms. Or maybe we're teaching them how to pay for that cup of coffee and figure out how to fit in that $6 Starbucks drink in their very limited budget. Maybe we help them find a more affordable coffee shop. So those are just some examples of how these different environments are all expected to be, inclusive in supportive housing settings. So why start these services in the IMD setting? One of the reasons that it is so important for us to deliver services that communicate hope, which I believe supported employment, supported education, and supported housing all do, because again, we're trying to move people from the most restrictive to the least restrictive setting. We are also infusing hope into the individual that we are serving. So I don't know about any of you, but if you've ever been hospitalized for any reason, it's really scary. The longest hospitalization I've ever had was 5 days when I gave birth to my son. And you feel very disempowered. Even me, without these other struggles, felt very disempowered. It was a emergency C-section birth. My son was intubated. There was a lot of stuff going on. And I felt like I can't do anything to help this situation. One of the things that supported housing services through FCS can do for folks is to help start to infuse some of that hope and sense that things can get better. I may be here now. I may be in a really restrictive setting now with folks watching me and with folks kind of, scheduling my schedule for me, telling me what I need to do. I have to attend this group. I'm going to attend this session with a doctor. I'm going to take these medications. But at the end of the day, the goal of supportive housing is to put ourselves out of business. That's scary. But there's always going to be people that need our services, right? There's always going to be people that can benefit from the knowledge that we want to give them and from the skills that we want to offer them so that they can recover and flourish. And that is why providing these services in the IMD setting is so important. Can also expedite discharge as well. The person is more hopeful about their future. If their self-efficacy, that is the belief that they are able to enter into housing and recover. If their self-efficacy increases because of an increase in hope and an increase in skill set, they are less likely to be rehospitalized. Next slide. So supportive housing services in inpatient settings can really offer, again, and I may have said some of this already, but let me make sure I don't miss anything. Their IMD settings are opportune environments for folks to identify things like housing preferences, which we referenced earlier, complete skills-related assessments. So again, excuse me, really assessing what kinds of skill sets the individual has so that we can learn or strengthen specifically housing related skills. So those skills that the individual is going to need to be able to increase their community tenure. To even begin a housing search, I don't know about you, but years and years and years ago, when I was thinking about looking for an apartment, I opened up this little rental guide. There's this little paper thing that used to be in like all the convenience stores around us. We have Wawas. You guys may have something else. We have Wawas and 7-Elevens, and it was always be in the little like lobby or the entryway. And that's how we did it. Or it was word of mouth, right? Now it's different. Now people are going online. For individuals who don't know how to navigate the internet, they may need to learn how to do that first, right? So we can't assume that a person knows how to look for housing. And to connect with peer providers. As Veronica said earlier, as a peer provider, you can offer a different perspective. And peer providers also help non-identified peer staff, so the case managers, the housing specialists, to understand what that individual is going through, to understand what their needs may be when we overlook them because we haven't necessarily shared the same experience. So I think that peer support specialists not only educate and benefit the individual we're providing services to, but benefit the entire team in that way. It can also, as I said, convey hope to service recipients and belief from others. And that is really important, right? When we feel at our lowest, when we feel like we just can't do this anymore, having others believe in us and articulate that and show up every day or every time we're supposed to meet with them and encourage us really makes a difference. And I think that all of us know that from real experience. So that belief that recovery is possible, even during times of psychiatric crisis, when symptoms may be at their peak, is extremely important. Because again, we want people to hold on to hope in times of despair and struggle. And providing these services in the IMD setting allows staff and service recipients to start to build that therapeutic rapport, to start to build that trust. Even little things like saying to a person, I'm going to be here every single Wednesday to meet with you. Or I'm going to be here, we're going to meet every day at 10 a.m. and we're going to get through another part of this housing preference checklist or whatever it might be that we're working on, or I'm just going to get to try to know you and have a conversation with you. Starting to build that consistency helps with individuals, especially if those folks who are coming into the inpatient setting to meet with the individuals are also going to either follow them into the community or help with a warm handoff to the community providers so that individuals don't fall through the cracks, so that individuals don't feel like their discharge was rushed and that they were just another number or person or patient to get out the door, right? We want it to be a soft handoff because this could be a really stressful and traumatic time for individuals, especially individuals who have dealt with trauma, who have felt abandoned in the past. We don't want folks to feel abandoned. So it will reduce the chance that individuals fall out of contact are lost to contact, relapse, maybe rehospitalized, or may end up in other more restrictive settings like jails. Next slide, please.
Okay, I'm going to take over. And so I want to talk about some of the ways that we do all of the things that Dawn just mentioned. So all of the, assessments and the tools and the interventions and the things that we can do with our clients and with the service recipients to provide them with the skills and supports that they need. So let's talk about some of those tools and interventions that can be really helpful when we're providing those kinds of services. So the first program is called Tools for Tenants. Now, Tools for Tenants is a public toolkit from SAMHSA, which is the Substance Abuse and Mental Health Services Administration. They put this toolkit out to help states develop supported housing programs. So our team at Rutgers, though, took this toolkit and adapted it to create a curriculum specifically designed for service recipients in the state psychiatric hospital to help them prepare for discharge to the community. So a lot of those checklists and assessments and housing preference surveys that Dawn mentioned are actually in this toolkit in Tools for Tenants. And we, like I said, adapted it for use in the hospital system. So I'm gonna come back to that a little bit more fully in a minute. The next program is Illness Management and Recovery. Do you guys have an IMR, illness management program in Washington? I'm not sure. If somebody could let me know if that's something that you all do. Feel free to type in the chat box. And as you're doing that, I'll tell you, if you don't know what IMR is, Illness Management and Recovery is a structured program. It's a manualized program that helps individuals with mental health conditions seek meaningful goals for themselves, acquire information and skills to develop more control over their psychiatric illness, and make progress towards their own personal goals that are meaningful to them, whether that's going back to work, back to school, living out in the community, reconnecting with family, developing social supports, whatever that individual sets as their goal that's meaningful to them. We want to provide them with the information to be informed decision makers in their treatment and in their progress in their recovery to get to their goals. Abita said, no, we don't at our workplace. We have ISP, and that sounds like the same thing. So ISP, can you tell me what that is? What that stands for? Okay, I'm gonna wait for Abita to type, and it only says to panelists, so no one else can see that. That's what I'm waiting for. So as I'm waiting for Abita to type what ISP is, I'll tell you a little bit more about illness management recovery. It's a program that provides a lot of education. So it does have some psychoeducational components to it, but it also has a lot of experiential activities and exercises that really help people on their recovery journey and to help them manage their illness in a way that they can live independently wherever they choose. It also has a lot of things that can be really helpful in supported housing environments, like building social skills, and also things like behavioral tailoring for medication and medication self-management, which we'll come back to in a bit. Oh, so Abita said ISP is individual service plan. Yeah, so where we want to address individuals' needs, illness management recovery encompasses a lot of information. So this program looks at recovery strategies and practical facts about mental illness, and it looks at the relationship of the stress vulnerability model for the development and what causes mental illness. It looks at coping skills and coping with persistent psychiatric symptoms, developing a plan for medication management and avoiding drugs and alcohol, and developing a sobriety plan and developing a relapse prevention plan. So it's a really very comprehensive kind of program. If you guys are interested in training on illness management recovery, we would be happy to provide that for you. But in terms of supported housing, the what really stuck out to us was the behavioral tailoring for medication, which is like, how do we help people? We know that a lot of people aren't successful in the community or return to the hospital because they don't take their medication. And we're not here to tell people that's what to do, but we want to make folks as well informed as they possibly can be on how the medication can help them. Kimberly said there are many agencies that utilize IMR. Oh, that's great. Good to know. We know that studies of the IMR program have found an increase in participants' knowledge of mental illness, their ability to cope with psychiatric symptoms, and an improvement in distress related to symptoms, have hope and progress in their goal achievement. And there's one particular study that's been done on IMR by our colleagues on the Rutgers team, Tom Bartholomew and Michelle Zechner. They did a study with IMR participants who had IMR in a psychiatric hospital, and they found that for every hour of IMR that the individual attended at the hospital, there was a 1.1% less chance that they would return to the hospital. So IMR really has the potential to increase community tenure after discharge. And in addition to those kind of manualized or evidence-based practice types of programs, there are several independent living skills and interventions that could increase success, like nutritional education, conflict management skills, maybe guidance on grocery shopping, and as Dawn mentioned, like financial education, creating a sample budget, even just, the simple things that we might take for granted that people or assume that people should know, and they may not. So those are some kinds of things that we want to think about when we're providing these interventions. So let me tell you a little bit more about the tools for moving on, or tools for tenants, the program that was developed by SAMHSA. We adapted it at the Rutgers team, who works in the state psychiatric hospitals in New Jersey, adapted this program to meet the needs of the folks in the psychiatric hospitals who were preparing their transition into the community. So all of the kinds of things that Dawn was talking about earlier, we made sure that they were in this adaptation. So things like exploring housing choices in the community. There are many folks who are in a hospital who don't really know what's available. They might think, oh, well, there's a group home, or there's living on my own, or there's living with my family, period. They may not know all the in-between options that are available to them. One of the things that we do in this program is to identify like what your rights are about in housing. A lot of folks who have experienced institutionalization, whether it's a hospital or incarceration, or experiencing who have experienced homelessness, maybe don't know these things, right? They don't know what their rights and responsibilities are, what their rights are as opposed to the rights and responsibilities of a landlord. So it's even just education. Then, as Dawn mentioned earlier too, what's so important is to explore and discover what's important to the person in their housing choices. So we want to set people up for success. And we know that if folks are in a situation that they're really unhappy about, they're not going to be as successful as they would be in an environment that they really are choosing. And we'll talk about that a little bit further. And from those choices, we want to help people develop a personal housing goal, and then assess the skills that people want and need, that will help them live independently. And then identifying and developing supports for successful community living. What supports do you have? What supports do you need? What do you need to learn? So we look at housing choices, preferences, tenancy skills, and support needs. This is one example of a housing skills checklist. Now, I have the link down here. This goes right to the SAMHSA toolkit, but this is kind of one that we adapted. And you can access the one from the SAMHSA toolkit, and you can have access to this list. But this checklist addresses several areas of independent living skills. So it's broken down into general supports, maybe ADLs, medical and mental health services, vocational skills. And this helps people look at what areas that they might already have and what ones they need, or perhaps they might need to refresh or relearn them after not using them for a long time. So if someone's incarcerated or homeless or in an institution or a hospital, maybe they had that skill once, but they haven't used it in a very long time. So maybe they need a refresher. Or maybe, like we talked about earlier, maybe they, the onset of their illness was at that critical skill development time, late teens, early 20s. Maybe they never learned it in the first place. Maybe they never had an opportunity to live independently outside of their family's home or outside of a hospital setting. So we want to kind of assess where someone is in that process. Do they have the skill? Do they need it? Do they need refreshed? And these are just snippets. Like there's a lot more involved in this checklist, but it's something that might be really helpful in providing these services to kind of figure out where people are in terms of the skills that they already have and what they need to learn or what they need refreshed. So we find that this is a really helpful thing. And you know what? We find also that when we're doing this checklist with folks, it's not only helpful to know what people need, but it's also kind of reaffirming to know what you already know how to do, right? It tends to help build people's confidence when they know that, oh, I know how to do that, or I can do that, or I don't need help with that. It kind of, affirms what the person already has and focuses on their strengths. So we want to do that too. That's equally as important as assessing what skills the person needs to learn, is to affirm and focus on the strengths that they already have. So this can be a really, really handy tool. This is just another example of some of the information that we have in the Tools for Moving On manual. So, we find a lot that service recipients tend to think, well, you know what, the staff is just here to help me, or, what do they do? And so we tell them, staff can help you by finding a place that meets your needs, whether it's an apartment or a room or house in the community. Staff can help you with applications and interviews, and, can actually work with the landlord with you. And then staff might help you be able to get settled or turn on utilities and, help you with furniture vouchers. And then staff will support you to keep your housing, right? They want to make sure that you're going to get all the resources that you need to help you maybe manage your money, get along with neighbors, keeping your space clean and safe, whatever services that they can help you access to be helpful. And this is also a checklist from the SAMHSA Tools for Tenants Toolkit that is publicly available and free, that you might find really helpful. And this is just a very small snippet. This is a multi-page kind of checklist. But this is where we talk about housing preferences. Like, what kind of living arrangements do you want to be in? What kind of neighborhood would you like? So, what kind of living arrangement? So do you want to live in a house? Do you want to live in an apartment? Do you want to live with, a lot of people around for support? Would you prefer to live by yourself? Would you like to live with a specific person, a friend or family members? if you did have to have a roommate, what would you like that person to be like? But also, in addition to the living arrangement, but what kind of neighborhood do you want to be in? Do you want to be in the city where you can walk to the corner store? Or would you rather be in a more rural type of environment? If you have that choice, of course, and I know Washington is a huge state with such a variety and varied kind of uh, opportunities for living arrangements. But do you want to be in a rural environment where there's trees and it's pretty and it's peaceful? Do you want to be close to public transportation because it's important to you to, be able to hop on the bus or the train and get to see people or to get to appointments or to get to work or school? And what support needs are available or needed in your housing preferences? Do you want to be in a place where you have support every day? Do you want someone to pop in once a week, every 2 weeks? What does that look like, and what needs do you have? Do you want to be in a place that provides activities, or that are activities close by? Or do you need a pet? Would you like a pet? Do you want to be in a place that, that's a deal breaker if you can't have a pet? So this is a really important exercise in creating that personal housing goal. And while it's important for the person to understand that they may not get everything they want on their preference list, it's important to have the discussion about the things that are important to the person. And that can really be critical to their success in the community. And this could take several sessions, depending on the amount of discussion that you have. But we find when we're doing this checklist, people are really into talking about their past experiences and what they've learned from that and what they might like moving forward, or what they would prefer moving forward. I mean, think about your own self. If you've ever looked for an apartment or how, to buy a home, you have your wish list, right? And then you have your, things that are absolute deal breakers. But you have the things that, my ideal situation would be this. My ideal situation would be, to live on my own in an apartment with a dog. Maybe your second choice housing goal might be, okay, second choice might be, I would live in an apartment with a roommate and a cat. I don't know. But we want people to understand that you can learn a lot from the things that you're really wanting and the things that you prefer. And it's a really good way to build that rapport with your clients. As Dawn mentioned before, developing that relationship and that trust is a really important part of the process. So we want to help people, develop that rapport with us. Doing this kind of exercise is a really good way to do that, because it shows that as the service provider, that you're listening, that you care, that people's needs and wants and preferences and choices are really important. And while, again, it's really important to reinforce the idea that you may not get everything you want. I didn't get everything I wanted when I bought my house. Sometimes that's life, right? Like, you can't have everything all in one place, but you really want to identify the things that are most important and kind of work from there. So this is a great exercise and tool to use when you're working with someone in that process. And then finding community supports. Community tenure, as we know, can be increased if individuals have access to the supports and resources for successful community living. So it's important for individuals to know what supports they already have, again, can be really affirming, and which ones they might need and how and where to find them. So this checklist, again, is from the Tools for Tenants, free and public and available. But it's also broken down like the preferences in general support services, vocational supports, supports around independent living skills, community resources, supports around health, medical, mental health services, and social supports. So this exercise helps people explore what supports they have in place, what supports they need, where they can find the supports, and how to develop those resources in the community. And it's broken down into those sections because I think, a lot of people tend to think of supports in terms of, oh, friends, family, my case manager. But it can be so much more than that, right? Friends, families, family, neighbors, peer support, like we talked about earlier. Maybe it's spiritual community members, self-help centers, case managers, housing providers, your primary care doctor, nurse, dentist, those medical professionals that might be support to you or to them. Community mental health programs, self-help groups, your counselor. Like, I think we want to help people explore that supports can come in all different shapes and sizes and in all different kinds of areas. And then finally, another exercise that we do after the supports is think about what supports, you need to maintain your housing, or what has helped you succeed in your housing in the past. So this exercise is really helpful in not only identifying the supports that someone needs, affirming the ones that they have in place. It's really helpful for individuals to be reminded of this, like, hey, here's all the people in your life that you have. And we ask people to just, picture them as the stick person in the middle of that circle there, and then fill in the circles with the supports that they have so that they can see how they're surrounded by the supports in their life and where those can come from. So that's just one idea of, how to look for, how to help people identify those supports. And then just jumping back to illness management and recovery for a minute, I mentioned briefly before about behavioral tailoring for medication. We know that individuals who are in inpatient settings often don't really have the opportunity to practice taking their own medication. We also know that medication non-adherence can be a big contributor to rehospitalization. So by helping people understand their medication, identify strategies for incorporating their medication into their lives, mitigating side effects, and ways to remember to take their meds as scheduled, people can be much more likely to take their medications once they leave. Think about some of the, if you think about the folks that you might work with, think about the medications, or at least people who have come out of a psychiatric hospital. Think about the number of medications that they take, and how overwhelming that could be. And this includes non-psychotropic medications too. Maybe they're insulin injections. And we see those often as barriers to finding the most independent housing for fear of inadvertent self-harm, maybe taking too many medications, maybe missing medications. So we know that medications could be a really big deal for helping people be successful in the community. So illness management and recovery has this whole module on understanding the role of your medication. So what is the role of my medication in managing symptoms? And again, this could be for psychiatric medication and non-psychiatric medication. How do we identify the difference between a side effect and, a symptom of the illness? How do we identify the side effects of medication and deal with those side effects? How do we talk to our doctor about the side effects that we're experiencing? And how do we learn enough about our medication to understand what it does and how it makes us feel, and the risks and the benefits of the medication versus the side effects, and then making an informed decision about that, and being a shared decision maker with your physician. Like, how do we get the best results from medication? One of the ways that people get the best results from medication is to take it consistently, or at least in the way that it's prescribed, right? So maybe that's helping the person develop a routine in taking their meds. Maybe it's helping them associate taking their meds with a behavior that they do every day. Maybe it's setting up a pill box or putting an alarm on your phone to take the medication at the same time every day. Or maybe it's putting that pill box next to your coffee pot or toothpaste in the morning so that whenever you reach for that thing, your medication is right there. So we want to do these activities that help set people up for success. So this is just one of the components of the illness management recovery program that's really important, because we know that, we see people return at least to a psychiatric hospital most often because they stop taking their medication, because either they're overwhelmed or they don't understand the role of their medication in managing their symptoms. They think, oh, I'm discharged now, I'm out of the hospital, I don't have anyone handing me a cup of pills at a window, and hey, I feel better, so I must not need this anymore, which we all know is what helps people to compensate and end up back in a psychiatric hospital. So helping people understand the role of medication and why they need to take it, and being informed decision makers in that process can be really helpful. So partnering with community providers is so important, because the staff who provide services in the IMD setting don't follow the service recipient. So we know that from focus groups that we've run, that most patients express that their discharge was abrupt, disconnected, and they weren't fully aware of the process or what was to come next once they were in the community and they felt lonely and scared after discharge. So beginning the process while inpatient reduces those abrupt transitions. It helps to, build that continuity and that seamlessness, and serves as a safety net for our service recipients. So this practice can, reduce those anxieties, the risk for loneliness and helplessness once they're in the community, as the person will be able to identify that through the process who and what their supports are that they choose, and then in turn will reduce the chance of relapse, rehospitalization, or homelessness. So I know at this point, if no one has any questions, we have an opportunity for a summary and discussion in a bit, but I know that there was someone here, I don't know if it's Kim or Amanda, that was going to speak to you about how you can follow up on these, about becoming a supportive housing or FCS provider.
I know that Kimberly had to leave. I'm not sure if Amanda is still here or not.
Okay. So I was trying to give someone a minute to raise their hand or something, say, oh, I'm going to talk.
No,
All
it
right.
doesn't. Amanda's not here, it looks like, and I know that Kimberly left.
Okay. Well, I know that who do they contact on if they're interested? The FCS folks?
So they should contact Kimberly Castle for questions specifically about becoming an FCS supportive housing provider.
Okay, great. And I, at the end of the slide, I have a phone number or at the end of the presentation, there's a phone number I can pass along to you. But so just to summarize what we talked about today before we open it up for discussion, is that supported housing or FCS services are a valuable option for people in IMD settings. Those services can be integrated into the person's therapeutic interventions already being provided. It provides that seamlessness and continuity of care to reduce, to make that community tenure more successful. And supported housing FCS communicates hope that recovery is possible despite the presence of psychiatric symptoms. Thank you, Abida. Thank you. So let's open it up a little bit. And what questions do you have about this process or any of the interventions that we talked about? Or any of the tools that could be helpful? And I'm going to just go back for a second because I want to just copy this and put it in the, whoops. I can't do it. Okay. I just wanted to make sure I put this here, even though you'll get the slides that have all this information in case you wanted to take a look at some of those tools and activities that I mentioned from the Tools for Tenants toolkit. That's there.
So Samantha typed in the chat box that in Washington State, they have a supportive housing service through Aging and Long-Term Support Administration, or ALTSA, called, gosh, I love that, Governor's Opportunity for Supportive Housing, where we assist clients in behavioral health settings move into independent housing with supportive housing services. If any agencies are interested in contracting, they can find the information on our website. So it's listed there.
Thank you very much, Samantha.
Thank you, Samantha. That we appreciate that. And she's jumping off to another meeting. We know what that's like.
We do indeed.
Good luck. Good luck,
Yeah.
Samantha.
Anybody have any other questions, thoughts? I have. As you're thinking about questions or thoughts, I want to share with you an additional resource. Oh, thank you, Samantha. I want to share with you an additional resource. So this is the Rutgers State Hospital Psychiatric Rehabilitation Initiative website. That's the program that Dawn and I work on. So we consulted all of the state hospitals in New Jersey. And Dawn, can you put the website in the chat box for me?
Sure can.
While I talk about it. So we created this website at the beginning of the pandemic to have a place to offer support and resources to the New Jersey State Psychiatric Hospital staff. So we have all types of staff resources, online trainings. I think there's about 30 something trainings that are free and available to anyone. There's all kinds of, initially there was a lot of COVID-19 resources. There's working from home resources and just virtual support opportunities for staff. And then there's also a section on how to become a mental health practitioner through our department university curriculum through Rutgers. They offer an associate's and bachelor's and master's and doctoral program in psychiatric rehabilitation. But the becoming a mental health practitioner is that, you know, maybe information courses that you might be interested in. But the online trainings and surveys section that you can see here, those are all free and available to anyone. You can even, at the end of each training, you can get a certificate of completion. So if you needed to have that for your file and show that you attended this course or took this course on your own time, that's a really helpful thing to have. Anything else on this that I missed, Dawn?
Well, I just wanted to interject, Jen, about the certificates. Whereas these trainings, the online trainings, are not necessarily approved for CEUs at this point in time. And I know that's important for some people who might be nurses or social workers. One of the things that, I know I've had experience, and other people who have used these or taken these courses, these online trainings, I'll say, one of the things that people have been able to do is they have been able to show their certificate to their employers to demonstrate continuing education. And also in some cases, people have been able to submit the proof of completion and scoring that they participated in these online courses to their oversight bodies. So meaning an individual is a social worker, or if an individual is a nurse, if an individual is a psychologist or otherwise certified, you may still be able to obtain credit by taking these courses towards any kind of annual or recertification requirements that any certificate or license may require of you. So I would say that, like, I would check with your employer. I would check with, if you're a social worker, check with your board to find out if any of these could in fact count towards some of your annual or ongoing continuing education requirements.
Yeah.
I know that you all just want to learn for the purpose of learning, but I also know that we have, needs that we have to meet in terms of recertification and things like that. So I did want to put that out there, that it may be possible for you to get continuing education credits by submitting those certificates.
Yeah, absolutely. And the trainings range from, 15-minute trainings to hour-and-a-half trainings and kind of everything in between. So there's really something for everybody, and they span across a wide variety of topics that you may find very helpful. So any last minute questions, comments? Again, you're going to get these slides and the link to the recording for the webinar that will have all of this information in it. So we really appreciate you coming today. We appreciate your time, your attention, and your participation. Just as a reminder, today's webinar was hosted by DBHR through the Washington Healthcare Authority. We'd like to remind you, like I just mentioned, that the slides and a link to the recording of this session and all of the resources that are on here will be available in the follow-up email. And don't forget to check out the Foundational Community Supports newsletter for all things FCS and upcoming training events. If you would like more information on becoming an FCS provider, you can reach out to AmeriGroup. There's the phone number there. And we thank you all for coming. And hopefully we will see you again soon at an upcoming webinar. I know we have one scheduled for July, Dawn? I'm not sure. July, the second week in July?
Yeah, I believe so. And I believe, you know what? I'm not even going to guess what the topic is. So
Okay.
I don't want to say something wrong. So just be on the lookout for the next announcement for the July. It'll be mid-July topic, supportive housing topic.
Right. All right. Well, thank you all so much for coming today. Hope you have a great day and a great weekend coming up. Thank you. Thank you.
Thank you all. Have a beautiful day.
I'm going to stop recording.